Welcome to The Explainer. Have you ever wondered what the most successful biological killer in human history actually looks like? Well, today we're turning a fascinating medical presentation by Dr. Hamasu Umar Takamawa into a bit of a biological detective story. We're going to track down an ancient, silent pathogen that has literally been hiding in plain sight for millennia. Our goal today? To really dig in and understand how this microscopic killer operates, how it completely dodges our best defenses, and exactly what it takes to unmask it and take it down.
Right off the bat, let's just throw out the biggest, most common misconception about tuberculosis. If you're sitting there thinking TB is just a really bad cough, you are severely underestimating our culprit. Dr. Takamawa hits the nail on the head here, setting the stage for a much more complex medical mystery. He calls it a multisystemic chronic disease with myriad presentations and manifestations. Basically, this isn't just a lung issue. This is a full-body invader that can strike almost anywhere.
And the stakes of this investigation? They couldn't be higher. This pathogen isn't just common. It's the single deadliest infectious bacteria on the planet. It is the most common cause of infectious disease-related mortality worldwide. Just think about that for a second. That means it takes more lives than so many of the newer, flashier viruses that make the headlines today. We aren't tracking a minor bug here. We are tracking a highly adapted microscopic killer that has perfected its survival over thousands of years.
Section 1. The culprit's profile, a biological fortress. To catch this specific culprit, the Mycobacterium tuberculosis complex, we really need to understand the biological weapons and the heavy armor it relies on to survive. So, the first real clue to its identity is its classification. It's an acid-fast bacteria, or AFB, and this is absolutely crucial, because this unique physical trait is exactly how medical detectives detect the bacteria in the lab. When scientists use really harsh acids or alcohol during standard staining tests, normal bacteria, they just lose their color, but not TB. It completely resists the decolorization. It stubbornly holds on to the stain, glowing brightly under specialized microscopes. It simply refuses to be washed away.
So what makes this microscopic armor so impenetrable? Get this, 60%, an astonishing 60% of the bacteria's complex cell wall is made entirely of lipid, which is fat. Imagine trying to dissolve a thick chunk of candle wax with water. It just violently repels it, right? This dense, waxy lipid layer acts as an ultimate shield, protecting the bacteria from our body's natural immune defenses and the harsh chemicals we use in the lab. This waxy armor, built from complex molecules with names like wax-D, makes these slender rods incredibly tough. Because of this shield, they are highly resistant to drying out and can easily survive direct hits from strong disinfectants. They also have this sneaky chemical called cord factor. This essentially tricks our body into launching a massive immune response, forcing our own tissues to build protective walls called granulomas right around the bacteria. But you know what their greatest weapon is? They are slow growers. They don't rush in and burn out quickly. They patiently, methodically build their fortress.
Section 2. The crime scene, not just a lung disease. So, with our culprit fully armored up, we follow its trail into the human body. We'd normally expect to find it all in the lungs, but as we look closer, we realize it is dangerously multisystemic.
Check this out. By comparing these two very different clinical presentations, we clearly see the big twist in our mystery. The classic violent lung symptoms you'd expect are on the left: a hacking cough lasting more than 2 weeks, fever, drenching night sweats, and coughing up blood. But contrast that with tuberculous meningitis on the right, a quiet, stealthy brain infection. A patient might just complain of an intermittent headache for a few weeks, seem a little confused, and have zero fever. It's the exact same bacteria, but a totally different crime scene.
And it doesn't stop there. This perfectly illustrates how far the bacteria can travel once it gets past the initial defenses. It can infiltrate your bones, causing lower extremity paralysis or severe arthritis in just one single joint. It can move into the genitourinary system, presenting as severe flank pain or mimicking other pelvic diseases. It can even travel all the way down the gastrointestinal tract, causing non-healing mouth ulcers or chronic diarrhea. It is an absolute master of disguise, throwing doctors completely off its scent.
Because the bacteria can strike pretty much anywhere, when a doctor actually physically examines a patient, the clues are all over the map. It depends entirely on which organ is under attack. You might hear abnormal breath sounds, called rales, if the lungs are wrecked. It could be unexplained confusion or a sudden coma from a brain attack, It might even show up as swollen lymph nodes, strange skin lesions, or severe inflammation in the back of the eye.
But here is the absolute kicker. Classic symptoms are often completely absent, especially in high-risk patients like the elderly or folks with compromised immune systems. A doctor might find zero significant physical findings during an exam. None. The patient could look completely physically fine on the outside, making TB a truly silent threat that demands a much deeper level of investigation.
Section 3. Unmasking a silent killer, the investigation. Because this pathogen can hide anywhere and show no physical signs, doctors can't just rely on the stethoscope. They have to break out a very specific set of laboratory tools to force it out of the shadows.
The medical investigation basically follows a strict three-step checklist. Step 1. We cast a wide net with a Manto skin test or an IgRA blood test to see if the immune system recognizes the bacteria. Step 2. The AFB smear. This is where we look at the patient's sputum directly under a microscope, hunting for those glowing, waxy rods we talked about. And Step 3 is the undisputed gold standard, the AFB culture. Actually growing the bacteria in a controlled lab is the absolute most specific test for confirming our culprit beyond any doubt.
Okay, but finding the active bacteria is only half the battle. We also have to talk about latent TB. This is a terrifying state where a person is fully infected, but they don't currently have active TB disease. The bacteria is basically lying completely dormant, walled off deep inside those protective granulomas, just waiting in the shadows for months or even decades for the perfect opportunity to strike.
So, what wakes it up? A drop in our defenses. The bacteria instantly reactivates the second the immune system drops its guard. This can be triggered by immune-destroying diseases like HIV/AIDS or medical treatments like systemic steroids. But even natural stuff, aging, diabetes, or severe malnutrition can give this incredibly patient pathogen an opening, which means almost anyone's immune system could eventually slip up and let a dormant infection turn deadly.
Section 4. The Takedown. Fighting and Curing TB. Let's move to the final phase and see how we take all this clinical data and use it to isolate the threat and eradicate it for good.
Step 1 is pure containment. Stopping transmission requires intense, immediate physical lockdown. Active TB patients are put in private negative pressure rooms, meaning air flows in but not out, trapping the airborne pathogen. The medical staff have to wear highly specialized disposable masks. In this lockdown, it continues without exception until the patient clears 3 consecutive negative sputum smears, 3 straight tests.
Now for the actual fight. To pierce that incredibly dense 60% lipid waxy armor we discussed earlier, standard antibiotics just will not cut it. Doctors have to deploy a heavy-hitting, empiric 4-drug therapy right out of the gate: isoniazid, rifampin, pyrazinamide, and ethambutol. All at once. Most everyday infections take 1 antibiotic. TB takes 4 heavy-duty drugs simultaneously just to break its defenses.
But, in the microscopic world, pathogens evolve. The bacteria are fighting back. We're increasingly seeing multi-drug-resistant TB, or MDR-TB. This frightening scenario happens when the organism mutates and learns to survive our best weapons, specifically showing resistance to both isoniazid and rifampicin at the exact same time. When doctors face this adapted drug-resistant mutation, the rules of engagement are incredibly strict. You can never, ever just add a single new drug to a failing plan, because the bacteria will just learn to resist that one too. Instead, you have to completely overwhelm it with a 5-drug intensive assault, followed by at least 4 drugs in a long continuation phase. It's not just treatment, it is an all-out pharmacological war. Which leaves us with one big, provocative question to wrap up today's explainer. TB is clearly not just a cough. It's an ancient, infinitely patient, heavily armored killer that can silently attack literally any system in your body. And as it continues to endlessly evolve and its waxy armor thickens against our modern medicine, will our ability to unmask and overwhelm it remain one step ahead? It's a high-stakes, microscopic arms race, and the detective work is far from over. Thanks for exploring the source material with me today, and keep questioning the world around you.